Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, I am Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Our topic for this podcast is gender bias in healthcare. And this is a topic that I really wanted to dive into because being a woman, being a mother to girls, I know I've personally been affected by gender bias, and it affected my health outcomes, just like many other females. And joining me to host this discussion is Dr. Scott Giles. Scott, thank you for taking the hosting mic today so that I could discuss gender bias in healthcare.
I appreciate the invitation. It's a very interesting topic, and just in our kind of pre-recording meetings, I've learned a great deal about it, and I'm looking forward to seeing where this goes today.
Yes, thank you so much for stepping in, and the floor is yours, sir.
Okay, well, let's jump in. There's a lot to discuss, and this, like as you said, is part one of part two. So we'll be more maybe defining the problem a little bit more today, and then in our future session, we'll be getting to some solutions, which is exciting as well. So, Candace, why don't we jump right in? Tell me a little bit about what is gender bias, and how does it typically manifest itself in the healthcare setting?
Well, when we talk about gender bias, we're referring to the preference really for one gender over another. And we're going to see that oftentimes it stems from these deep-seated beliefs about gender roles and the stereotypes of the genders. But in healthcare settings specifically, you're going to see this manifest in a lot of different ways, such as how we interpret symptoms, the treatment types that are offered, actually even the level of seriousness with which patient concerns are being taken. So an example that I have is women's symptoms of heart disease. A lot of times they're often underdiagnosed or they're misdiagnosed when we compare it to men. And this leads to disparities in treatment and in their overall outcome. We know that heart disease is the leading cause of death for both men and women. And we also know that it presents differently, can be significantly different in how it presents between genders. And so women often experience more of those subtle or atypical symptoms when compared to men, which is what leads to that underdiagnosis and that misdiagnosis. And I know that as we go through this discussion today, we'll touch on why atypical symptoms can actually lead to misdiagnosis and underdiagnosis.
It's interesting, Candace, because when we talked about this a little bit early, and so I just for fun this morning, as I was just getting ready, I just did a quick Google search and I just put signs and symptoms of heart attack, and I just went into the first four opportunities that I was able to explore. And so I didn't know what to expect. I didn't know if I would find that there is differentiation in symptoms in terms of what was listed in these sources. And these were main, the first two were like Mayo Clinic, American Heart Association. These are mainstream places. But basically two of the four did address in signs and symptoms differences in terms of gender differences. So I thought, I don't know if that's good or bad. I mean, I don't know if I had looked at that 5 years earlier, if it would have been none of the four did. Right. And so we're really making progress, or I don't know, even myself as a physical therapist, that wasn't necessarily something that was in my mind, but obviously increased awareness just through our discussion and our preparation for this made me really want to see what's out there in the literature. So do you feel this is progress? Do you think 5 years ago we would have seen something different, or?
There's absolutely progress in this area. And I know that at some point we'll talk about the history, but we can actually walk through the history to see how women were excluded. And then when we started bringing women back into the research. So absolutely, we have made progress. Where you're going to see the lack of progress is in those biases, what they have been taught, what is in the medical books, and I'll talk about classic versus atypical. Is it really atypical symptoms for women, or is it classic symptoms for women? Is it the normal symptom? I mean, those symptoms, cardiovascular disease is not normal, but is that the symptoms for women versus being like, oh, well, the man these are the typical symptoms and classic symptoms, and these are the atypical symptoms.
Yeah, even that has a bad ring to it, right? They're atypical, like you
Hmm.
said. Yeah, they're atypical because of the way the research was done and how society has manifested that over time, not because they're atypical for women. Candace, I think pain is another example, right? Where men and women tend to be treated very differently. Do you want to touch on that a little bit?
Yeah. So women's pain is actually, if you look at the research, and I wrote a course for Elite Learning, you can probably find it on implicit biases. And I talk about how pain management in women is often taken less seriously than men's, which is going to lead to under treatment of the pain, but also misdiagnosis of the root cause. Because a lot of times they're going to minimize the pain that women have. They see women as whiny, and they also attribute it to psychological causes.
Yeah, this
But I
makes me
mean,
uncomfortable
women
in general.
give birth. Women
Yeah,
give
come
birth to
on.
babies, and you're saying we're whiny because we're complaining that we're in pain.
Yeah, I think any male who's being honest will be very clear that pain tolerance is
Yes.
perhaps the attribute of a female that is more effective. I know. Yeah, no thanks.
Yes.
I think there's a reason for childbirth being female
Mm-hmm.
centric.
Mm-hmm.
So okay, so these are interesting observations, but how does this really affect patient outcomes and healthcare quality?
Well, if you are looking at significant disparities in patient outcomes and healthcare quality when patients are affected by gender bias. I mean, let's go back to where we're saying women receive delayed diagnoses, they
Right.
receive inappropriate or inadequate treatments, or like we were talking about with pain medication, they pain management, inadequate pain management, and all of those things are going to lead to poorer health outcomes. For instance, if you look back at the heart disease in women, well, if we underdiagnose or misdiagnose, we're going to lead to higher mortality rates. And if we're also dealing with gender bias, you're going to erode the trust that these patients had in you as a provider. So that's going to lead to, like lower patient satisfactions. And unfortunately, when you are like, you've missed this 3 times, I've tried to tell you about it multiple times, and now you're telling me to do this, well, we're going to see lower adherence to medical advice. Like,
Sure.
I couldn't trust you.
No, yeah, exactly. And do you feel that, I mean, are we able to qualify and or quantify the impact of this? I mean, it's a tricky thing, I would think, from a
Mm-hmm.
research perspective to do, but do we have any sense of how we know it's a problem, clearly, even
Yes.
obviously anecdotally, but have there been attempts to quantify this information or qualify it to make it more on the
Yes.
front burner?
Yes, the National Institute of Health actually they continue to research this. They continue to gather data, review the data, and release that data to the public on this very topic. And there's also different things, and I know we'll talk about it later. I think in episode 2 probably, where we can talk about data that you could even collect within your facility
Hmm.
to help you look. I mean, you really need to look at the big picture and not just take pieces of it. You need to look at the big picture, and you need that qualitative data, but along with your quantitative data. Give me that patient feedback. How did you feel when you were talking? Did they listen to you? And you can use both pieces of data to give you that broad picture.
Interesting. I'm sure though. I mean, boy, that seems like a wonderful opportunity for future research. And I would hope there's a lot
Mm-hmm.
of, funding at
Mm-hmm.
the national level through grants, et cetera, in order to delve into that topic, because
Mm-hmm.
I don't think anyone can dispute the importance.
Absolutely. And I will say, I know we'll talk about the historical roots, but the National Institute of Health, they give a lot of money for a lot of grants and stuff towards research. And so they set the law down, not literally, but they said, we are not going to fund the research unless it is inclusive and follows a policy that was put into federal law back in 1993.
Yeah, it's amazing. Like many
Mhm.
things in our society, right? There's no quick fix, though, because I would think that many
Yeah.
of these studies are very longitudinally based, and so even
Hmm.
if dramatic changes were, to be made in current research and research moving forward, it's going to take years and in some cases decades in order
Yes.
for that new normal or
Yeah.
typical to be established, or at least that's my uninformed guess of how that would
Hmm.
work.
Well, we
Well,
know that gender biases, it runs deep because of the historical roots of it. And it does still continue to influence contemporary healthcare today.
And how did we get there? Let's talk more about this. Let's dig down a little bit on the historical
Yeah.
roots. Is this just because, men were conducting the research at the time and being this male-centric society that we were previously? I'd like to think we're not now, and I think we've obviously made some
Yeah.
great strides. But how did we end up in this typical atypical that's not accurate of the overall population?
Well, like you're saying, historically, women have been systematically excluded from medical research and clinical trials. And it was because at that time, it was more of that patriarchal societal structure that really influenced medical practice. But what we saw is that this inclusion was often justified by, and I get their concerns. I understand because back then there were potential risk of to women of childbearing age. And then, there's complexities that get added into that by hormonal cycles and things that we didn't understand back in the day. But even with our differences, what I find really interesting is that there seemed to really be a genuine belief that that your biology could be compared to mine. So the male
Right.
biology compared to women's biology. And that's why you see that there's this vast majority of medical research that's been conducted on males and not on females. But there is it was about 1977. It's when the FDA actually officially released a guideline that banned women of childbearing age from participating in phase 1 and phase 2 of clinical drug trials. And what I
Mm.
found really interesting about this policy is how broad these recommendations were for women. So they excluded women who were taking contraceptives. They excluded women who were single. Even like women whose husbands had a vasectomy were excluded from these clinical trials. And this is what really prompted the National Institute of Health in the early 1980s to start saying, hey, we need to start advocating for women to be included in these studies. And that's where you started to see the stand up of what we have today, the Office of Research on Women's Health through the National Institute of Health. But that wasn't officially established until 1990. And so
Wow.
in between 1989 and 1993, the National Institute of Health started to try to push policies through, start really advocating for women to be included. And it wasn't until 1993 that Congress actually wrote the NIH inclusion policy into federal law. It's in the National Institute of Health Revitalization Act of 1993. And if you go like on a Google search, if you're looking for it, it's titled Women and Minorities as Subjects in Clinical Research. And that's where I said earlier, they said, unless you are following and you are complying with this policy, we're not going to fund your research. And they did take a look at it in 2017 and make some updates to it. But the NIH, like I said, they're still gathering data. They're still reviewing. They're still releasing. They're paying attention.
Well, thank goodness. I mean, because
Mm-hmm.
to some extent, clinical practice is chaos, right? And
Yes.
people are just kind of functioning day to day, and some of these global issues, I think, have the tendency
Mm-hmm.
to go right over our heads, or just not even be on the front burner. And we'll get into the whole education side of it later, right? Because it has to
Yeah.
start there in terms of training these providers. But do you feel that okay, so there's been increased awareness, and groups like the NIH are paying attention to this, but I mean, how effective do you think it's been? Progress, yes, but do you feel that the majority, I'll say that the majority of research today is structured in a way that it meets both genders' needs? And I guess I would also ask about diagnostic testing, because there's a
Mm-hmm.
lot of testing, there's a lot of normative data based on those tests that I'm guessing was probably based on a lot of male outcomes and may not be reflective of
Mm-hmm.
female outcomes. So
Mm-hmm.
how about that in terms of those two pieces, in terms of where we're at today?
Well, when you said that you did your Google search and you opened it, you started to see, okay, they're identifying male versus female. And that's huge. And that's where we need to be. We need to say this is the classic for women, this is the classic symptoms for men. And we need to understand that. But let me just ask you a question to answer this question. But um, you probably don't have any issues with this, but I go to the gynecologist and they want to do a pap smear or a biopsy. I don't get any sedation for that. I don't get any numbing for that. It is not comfortable at all. Also let's look at hormonal replacement therapy. HRT, just a few years ago, it was like, you get hormone replacement therapy and you get it. You're perimenopausal, you're menopausal. And there was no true understanding of the treatment plan. And people would just be on it long term. And then we started finding out, oh, you know what? Long-term HRT can lead to cancer. It can lead to heart disease. There's so many other issues that could come about. And, the root cause of it is not understanding the women's physiology.
But I guess I just don't get, maybe it's because I'm a male, I don't get this, but I don't understand why, if there are certain procedures that, you mentioned with your OBGYN or screening procedures, and there's a consensus that this is painful. Like, this is not pleasant. Like, what would be the barrier in order to, I'm just picturing the dentist, like, okay, my dentist doesn't fill a cavity with nothing. And at some point, there must have been feedback that you know what, I need this. So why, it seems archaic. Why would there not be pain assistance needed? I just don't get it. Can you enlighten me on that at all?
I don't get it either. I think most women don't understand it either. I had a biopsy when I was in my 20s, cervical biopsy. And I actually yelled, not, I wasn't screaming, and I was shaking when they were done. When they were done, they left the room, told me I could get dressed. And my hands, I couldn't, my mom had to help me get dressed. It was so painful. And nobody prepared me for that. Yeah. And the thing is it was a female gynecologist that did that. But there wasn't even a second thought. They just walked out of the room like nothing ever happened. And I couldn't even get my clothes on by myself.
And it's so tough for people to advocate for themselves, right? And like you said, you weren't even informed enough. Like, you had no idea what was about to go down. So it wasn't like you could, in a preemptive way, be like, I'm concerned about the pain level. Is there something that we could do associated with this? It was just thrust upon you. And then, heaven forbid, you have to go back and have another procedure done. Now you're terrified.
Oh, I was.
You're probably less likely to go back because of just the experience. And it probably does undermine your confidence in your provider to some extent, knowing that you were treated like that.
You take it with you to every provider you go to because you're scared. Every time I go see a gynecologist, I'm like, I have to calm myself down because that erodes that trust. It's like, that it's that trust that's eroded because I don't feel that you took care of me like you should have taken care of me.
Yeah, no, I think that's completely fair. Well, look, in our society, we have all kinds of forms of bias, right, that we're dealing with, whether it's cultural, ethnic, socioeconomic, on and on and on. Do you feel that, I think with certain types of biases, in my uninformed mind, I tend to think, look, a lot of it is awareness. A lot of it is examining your implicit biases. Is there something we can learn from combating, and not always successfully, but attempting to combat these other forms of biases that can maybe speed up or ramp up the process? Like, we must have learned something at this point. I don't think gender bias is terribly different. How it manifests is different, but bias to some extent has some commonalities, no matter what type of bias we're looking at.
There are a lot of biases that intersect with gender bias and other forms of discrimination, like what you're talking about. And unfortunately, that's going to create more of these complex barriers to healthcare access and to the quality of care that we receive. So let's look at women of color. They often face that compounded discrimination because now you're a woman, now you're of a different race. And so you're going to see those racial and gender biases, which is going to multiply that negative healthcare experience. You also have socioeconomic status. It just adds another layer of complexity. You have lower income women who are going to have fewer resources to be able to even advocate for themselves, or to have the opportunity to seek alternative care when they face these bias treatments. And then you also can look at age bias. Age bias, and I know we're talking about gender bias, but age bias also in medical research often results in disproportionate focus on your adult population, particularly like our middle-aged and our older adults. And so you're going to see this manifest in funding allocations, clinical trials, and drug development. So,
it gets, the more you slice it and the more you stack these things. It's funny because I was thinking of more of, okay, what have we learned? What strategies have we implemented with these other forms of biases that could be effective, with gender bias? But it's funny. But then when you put it in the context you did, it's like, oh my goodness, it's worse than I even thought. We're just stacking these different forms of biases. And look, when they're as broad as, gender or socioeconomic or religious or whatever, you're rarely dealing with just one, right? I
Yeah.
mean, this is probably two, three, et cetera. And
Mm-hmm.
wow, it just makes it over. I mean, I guess thus the value of having a discussion like this, right? Because you have to
Yeah.
start somewhere, and you have to, part of it, I really feel is awareness and education that
Mm-hmm.
it is real. What do you feel about, I mean, what specifically does the research show that are the psychological and to some extent emotional impact of gender bias?
Well, the impact on your psychological and emotional, that's profound. I mean, that's huge. When patients experience gender bias, they're going to feel, well, invalidated, dismissed, misunderstood. You almost feel like, I mean, when someone doesn't believe you and you're telling the truth, how does that make you feel? And that's when it comes to your healthcare, it's really going to make you stressed out. You're going to feel anxious. You might even go
Sure.
into kind of a depressive state. You might even start questioning yourself. Is is this my reality, or am I making this up? What is happening? So again, that's going to cause a lack of trust because you're going to erode my trust in you and your abilities. It's going to lead to decreased adherence to medical advice. I don't know that I want to seek care if nobody's going to believe me. So there's that reluctance to seek care in the future. And then when you kind of have this cumulative effect, of these experiences, it really significantly impacts a patient's overall well-being and their quality of life. So it all goes back to poor patient outcomes. And if you have some pretty traumatic experiences, you can't rule out PTSD either.
Oh, yeah, I'm sure. Yeah, it's brutal, right? Because I mean, when you think about, our healthcare system, for those that don't engage in self-advocacy, we know the research shows that, that positive outcomes are clearly correlated with individuals who do advocate for themselves, et cetera. But if you feel demeaned, if you feel that you're not being listened to, if you feel underserved or your needs aren't being heard or met, then how on earth you're not going to advocate for yourself? You're going to
No.
most people will go into a shell and
Mm-hmm.
become a very passive participant of healthcare. And I think we know the outcomes that are associated with that, and they're not good. It's to me, it's a real spiral, right, and a downward
Yeah.
spiral when that exists.
Well, and I know for me, I had a personal experience where I faced multiple biases myself. And, mine were I was a female, I was young, and I was a military spouse. And I mean, military spouse, military in general, you usually have some type of bias there towards you. But I had made an appointment with my primary on base provider. And I told him in our meeting that like my stomach has really bothered me and I wasn't sure why. And he just kept telling me over and over again that I needed to see psych for anxiety. Even after I told him multiple times, sir, I have no reason to be anxious right now. I really don't think that this is the problem. But he did not assess my stomach. He didn't take me seriously. And that was early in the week. And by like that Friday, I was in the ER with my stomach so swollen, and I was in some of the worst pain. Even today, after having 3 kids, like I'm like the pain of that I was going through then, it was so much worse than childbirth for me.
Wow, that's saying something.
And yeah, so in the ER they did a CT scan and it showed my intestines were so inflamed. It was like my transverse colon all the way down to my sigmoid colon. And the doctor just walks in and looks at me and he's like, I cannot tell you if this is cancer or if this is an infection, but they are really inflamed. And so I, of course, being a nurse, I was like, is there any way you could just give me some IV antibiotics, a couple of doses, and then just let me go home and finish it out? And so I did. And of course, they tell you, hey, on Monday, go check in with your provider, just for your follow up. And so I did. I went in to see him on that Monday. He walks in, he looks at me, he looks at my chart, and he leaves the room and he goes and he calls the GI doctor to get me an appointment. So he personally called to get me an appointment with them. He did not apologize. He did not acknowledge that he failed me. And so many women of all color and age deal with the same type of treatment. And it left me with a lot of questions because I mean, I could have turned septic. I was probably on my way to being septic. And so I questioned, like, if he had taken me seriously, would I have ended up in the emergency room? If I didn't
Yeah.
go to the emergency room, would I even still be here today? But my care was so delayed. And my outcome was overall not good. They had to go back in for like, after he was like, do you want to do a colonoscopy today? Or do you want to wait till your antibiotic is done? And so, because he was like, I need to see what's going on. I need to know if this is cancer or an infection. I was like, just let me finish my antibiotics. And then, but the fact that he didn't even apologize or acknowledge.
Or take the time to engage in a meaningful physical examination.
Yes.
I'm not sure if this individual felt he was psychic or what the possibility is, because I mean, what are you basing that anxiety comment on with doing no formal examination? Now, look, you'd like to think this is just a terrible provider who had a really bad day. But we probably know that's not the case, right?
Yeah.
I think we know your example's illustrative of what happens a lot. Yeah. And just think about, I mean, I don't know you that well, but I think you're an very well educated. You're an assertive individual. You have beliefs. You're not going to get rolled over. I mean, a lot of people don't have the self-confidence that you have, or I don't know how much medical knowledge you had at that time, but either way, I mean, the outcome, I don't think it's dramatic to make it like, what, you might, like you said, you might not even be here. And that's not drama. That's reality of that situation as you hear it played out.
Yeah.
So that's makes me very unsettled to even think about that.
Yes. Well, let me walk you down another little rabbit hole that I have found really interesting with gender bias. But so we know that even if there was thought that the male biology could actually transfer over to the female body, we know today that it doesn't really work that way. So when you look at the medical knowledge that we have, I use this phrase, if it has to be in the context though, that the medical knowledge was primarily created by and for men, because women were excluded from medical education, medical research positions, being in clinical trials. And so that's why I'm saying it was created by and for men. And so we're really having to make up for that today. And so the issue from the fact that the focus on male subjects has led to this medical research paradigm where male physiology is still today considered the default for so many things. But what I found really interesting is that this male-centric approach in medical research has actually perpetuated the belief that because the male physiology is the norm, the female physiology is the deviation. So let's look back at the 19th century biological writings. We have Darwin, and he gave this notion that females were biologically inferior. And we still see that today. It's had lasting effects today. And then you have those Freudian theories where they were like, women's experiences contribute to a tendency to our physical symptoms are because of psychological causes, which, see, that happened to me. So let's go further down our little rabbit hole. And I want to talk about hysteria for a second. Did you know it was until Freud, it was believed that hysteria was actually the consequences of a lack of conception and motherhood. So they thought it was a disease of women. Okay. So I have a quote, and I want to read this quote to you from an article. The article is Women and Hysteria in the History of Mental Health. And so
I'm nervous.
It says,
to hear this.
Oh, all right. Here we go. Not only is a woman vulnerable to mental disorders, she is weak and easily influenced by the supernatural or by organic degeneration. And she is somehow guilty of sinning or not procreating. Thus, mental disorder, especially in women, so often misunderstood and misinterpreted, generates scientific and or moral bias defined as pseudoscientific prejudice. And we still see this today where women's physical symptoms are attributed to psychological causes.
I mean, I don't know how I feel when I hear that, except incredibly uncomfortable. I can't wait to drop that on my wife. She's going to snap. but I mean, I don't know. I mean, it's at one level, it sickens you. At another level, knowing it, look, it's not great maybe, but we've definitely made progress, but it's embarrassing maybe that we're still this is even a topic today that we have to talk about this. Yeah. So I mean, it's like everything, right? I mean, progress has been being made, but it's glacially slow. And, but people like you are fighting the good fight on this and bringing it out in the mainstream and making people aware of it, not just providers, patients, policymakers, and everyone. So I think, again, this topic will continue to emerge. It's clearly getting more attention than it used to, which is the only way this is ever going to change. Well, Candace, we're at the end of our time for episode 1. I really want to thank you for sharing your insight to help us better understand the root causes of gender bias and the impact on patient care and outcomes. Listeners, please be sure to carve out the necessary time to listen to episode 2, where we discuss specific strategies to reduce gender bias in healthcare. Gender equity in healthcare benefits everyone, improving patient outcomes, fostering trust, and promoting a more inclusive healthcare system. Thanks for joining us for today's episode.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.